not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
Hey guys, so this Rush episode was recorded live at CastleFest. And before we get into it, we want to let you know real quick what's going on with CastleFest 2014. We've been getting a lot of questions from excited folks who want to know details.
Yeah, I've already sprained my fingers like 3 times trying to respond to the inquiries. So in an effort to cure the world of carpal tunnel, we're going to go ahead and open up registration. The dates are set. The lineup is confirmed.
And it's as incredible as ever. Remember the incredible lectures last year from Weingart and Noble?
Yeah, they're coming back. And after a year off, we have the man, myth, legend, Chris Fox coming back. This time, sans broken foot. That's right, you get Fox at 100%. No limping this time.
Unfortunately, Mike Stone is not allowed back in the state of Kentucky after an unfortunate incident at the castle on a little-known defamation of Kentucky State Castles law.
The good news, though, is that we have Mike Stone coming in to take his place. I hear he gives great nerve block lectures as well.
And we've got some fresh meat for you this year. Andy Slose from the PIMED podcast, who can scan a little adult like nobody's business.
And the Haney Malamat from Critical Care Now fame. Guy is off the chain awesome with his critical care ultrasound knowledge.
Yeah, we're doubling down this year on critical care ultrasound and pediatric ultrasound, as well as giving you all the incredible basic stuff, MSK, and nerve blocks on cadavers that you've come to love.
And of course, all the activities still apply. You get to go head-to-head with Stone betting on ponies at Keeneland, get in a bourbon drinking contest with Weingart at Woodford Reserve, and watch Chris Fox do things that only Chris Fox can get away with in Kentucky.
Yep, and we're still having the management course. Adding a cookout at my house too this year. For selfish reasons, we realized that by far our favorite part of CastleFest is getting to meet all the amazing attendees.
So we wanted to spend even more quality time with you, and we're going to hang out at a party at Matt's house if you're still around for the management course.
The other thing we added this year is a couple of VIP King/Queen experiences. It includes all 4 days Cadaver Lab management course, plus you stay at the actual castle with the instructors in the couple of extra rooms we usually have.
And all your food and drinks for the entire week are completely covered. You never even have to leave the castle if you don't want to.
Our goal, as always, is to give you both the time of your life and teach you more than you thought humanly possible. So rest up and get prepared.
What you don't want to do, though, is wait. Sign up early or you'll miss out. They haven't expanded the castle any, so this will sell out again.
See you there.
Yes, we realize that it's kind of weird that we've never had a podcast about the Rush exam. In fact, we did record some audio with Scott Weingart on the Rush exam about 2 years ago now, but we never got around to using it. And by the time we did get around to it, we realized he was going to be covering it in depth at CastleFest 2013, so why not just wait and record him there? He's an epic speaker and is even more incredible live than on the podcast. It's pretty rare to find someone who is as charismatic and engaging in person as Scott is, and also completely brilliant and extraordinarily dedicated to his patients, and extremely generous with his time. The number of courses he teaches at in a year is mind-boggling, so we were flabbergasted when he agreed to come teach with us at CastleFest last year and this coming year as well. But he's much more than an incredible physician and great communicator. I think he is truly the most interesting man in the world.
Stay thirsty, my friend.
It's a pleasure to be here. How many folks listen to the podcast? All right, a bunch. And I appreciate that so much. I can't tell you what it does for me to be able to speak to people that listen and see you guys in person. It's a real pleasure. So if you listen, you know what I'm all about, which is the idea that patients who come into the ED should get the identical care they would get when their ICU bed opens, that it's unfair that geography would determine the level of care a patient receives, that if one patient comes in one day and there's an ICU bed open and they get care up here, and they come in the next, and since they're waiting for a bed, they get care down here. That is incredibly unfair. That's just not right. It never made sense. So bringing upstairs care downstairs, that's what the MCRIT podcast is all about. And that's what this lecture is about as well. Matt already said a bit about who I am, and it was mostly persiflage and over-complimentary. But I'll tell you what I'm not an ultrasound guru. And is there any way I could get a little light up here? Just a bit, tiny bit. That's perfect. All right, so I'm not an ultrasound guru. You know, I learned just enough ultrasound physics to pass my exams and then promptly forgot. And if you had any complex questions about diastology, I'm going to stand up here and look like an idiot because I have no idea. I don't have ultrasound gel at my bedside. I'm not quite sure why the ultrasound guys speaking to you today, they all do, and I don't know what they do with it. I don't think I want to know. I don't use the word probing in kind of off-color manner. But I'm an ultrasound user. I think it was the most important thing to come down in terms of diagnosing patients at the bedside. And this is upstairs care, downstairs. Because upstairs we have a range of hemodynamic monitors that'll go in various orifices and tell us all sorts of numbers that our poor cowering interns need to report on rounds that will give us the information that ultrasound now has supplanted. We get that same exact level of information, but we get it ourselves without having to do invasive procedures to the patient. So I'm going to talk to you about the rush exam. Now, I should always say I'm taking money from none of the ultrasound machine makers, no drug companies, nor will I ever. Okay, so the rush exam. This is not a new idea that I'm going to tell you about. When I was an intern, I think, all the way back in like 2000, 2001, I read this article, and it was on the undifferentiated hypotension protocol. And it was just a couple of, probe locations. You get a bunch of information. You find out why your patient is hypotensive. And it seems so cool. And I started doing it. And I'm like, this is great, because now I have all this information on a crashing patient I didn't have before. And I loved it. And the problem was that no one was really doing this. The stuff was out there, and there was other stuff in the literature as well. And I would come into a shift, and when I remembered, I'd grab the machine, and most of my peers weren't doing it. It just wasn't part of the culture to rapidly ultrasound the hypotensive medical patient. That was the thing. It just doesn't get done. Eventually, it always does. Patient's been in the department for a few hours, and now they're looking really bad, and then you say, oh, what's going on? And you eventually get the machine. But no one was doing it up front. So we came up with the idea of the rapid, because it should be quick, ultrasound for shock and hypotension. And so it's myself and a couple of my ultrasound buddies at Mount Sinai came up with the idea, and then subsequently this guy Phil Andrus and one of our ultrasound fellows, Amy Sangvi, have added to this.
Oh, I just had an idea. Since Scott wrote the Rush chapter with Phil and Amy, as just mentioned here, in our iBook, let's give some copies away. This book is on inkling.com now, so that it's available across all platforms. So the first 5 people to tweet to us at UltrasoundPod with the message, give me my copy of Introduction to Bedside Ultrasound on inkling.com, we'll send you a free code. We have a few left, and we just soon go ahead and give them out. Sorry for the interruption.
And what I should say, just to put it out there, is there is another exam called the Rush exam as well, you might see in the literature, by a different group. And we published ours first, and the only thing I will say about it is that our second-hand sweeps. And anyone who's been to Times Square knows you want your Rolex to have a sweeping second hand. All right. So this concept that nobody was doing it, that's what this is all about, is when you get a bad trauma, how many folks are doing a fast exam on them? Show of hands. Everybody. It's part of the culture now. In fact, for us, we get the patient onto the bed, we make sure their airway's okay, and we listen to their lung sounds. And then while someone else is trying to get IV access, I grab the ultrasound machine and I'm actually doing my fast exam pretty much within 60 seconds of their arrival onto my gurney, because it gives me so much information about that patient. So it's part of our culture in emergency medicine to do fast exams right up front. It's not part of the culture to do it on the medical patients, or at least it wasn't at the time we wanted this exam to start taking off, because it's probably equally valuable. In fact, a lot of the trauma gurus who haven't learned to use ultrasound yet would argue that ultrasound is pretty much useless in trauma. It doesn't tell us anything we didn't already need to know. But on medical patients, it's exactly the opposite. It's how you can immediately save a life. Now, when we started thinking about why are people so avid to do the fast exam and they're not doing it on medical patients, is we realized that it's brand selling. It's advertising. You see, the fast had a cool name. It's fast. Acronym, short, monosyllabic. That's good. And we realized that the undifferentiated hypotension protocol, they didn't sell it well. You see, they didn't get the consult with the madmen, right? They didn't find out how to sell this idea. So that's all we did, is we just reprocessed someone's great idea into a sellable product. That's how all good things come about. And so, we came up with the idea of Rush, because it's rapid ultrasound for shock and hypotension, so we're playing off that fast stuff. And we figured that would make it easier for folks to remember. So medical patients will get the same ultrasound exam. And the people it's for is patients with shock and hypotension. Now, the hypotension's easy. They have a low BP. You should be immediately coming to the bedside with your ultrasound machine and trying to figure out why. The other group, the shock group, are a little tougher to identify, because these are patients who have a big problem, but they haven't yet started to drop their blood pressure. And so how do you find those? I prefer the screening exam, the LLS sign. Are people familiar with this? This is it's pretty complex, so I usually just go on the computer to calculate it. I go to mdcalc.com. My friend Graham Walker has all of the clinical screening tests, like Wells score and all that, in an easy to find. And so I had Graham put up the LLS sign, because I could never really remember it as well as I'd like. And so he put it up on the site. And there it is. It's just the looks like shit sign. And if they do, you score them a 1, and then they have a positive LLS sign. And at that point, you should strongly consider bringing the ultrasound machine to the bedside and doing a quick Rush exam, because it's very quick, and it'll give you a ton of information about these patients. And this is only half tongue-in-cheek, because this is all it really takes. And often, I just remember before ultrasound, we'd have patients that, oh, he looks like crap. And then you just you throw up your hands for 2 hours until all the lab tests came back, and it's ridiculous. So let's talk about how to get this done. So the acronym to sequence this exam is HIMAP, because that's usually what you want in these patients, is a higher map. So HIMAP is the way this is going to play out. You're going to look at the heart, you're going to look at the IVC, you're going to look at Morrison's and the abdominal views, the aorta, and the pulmonary windows. And that's it. It really can be done in about 2 minutes. So this does not take a ton of time. The sequencing. I like to just grab the low-frequency phased array cardiac probe, pop over here to the parasternal long axis, try to get an apical 4 chamber, and then either with that same probe, or you could switch to the low-frequency general purpose abdominal probe, you come on over in longitudinal and take a look at your IVC, Morrison's, splenorenal, and pelvic views. You do what we call the aortic slide. You get your 4 views from the xiphoid down to the umbilicus for the aorta. And then you could either switch probes or stay the same, depending on which school of thought you're in. I switch to a high-frequency linear probe, and I pop on up to the pneumothoracic views up on top, just underneath the clavicles. And those are basically all you need. Now, there's some supplemental stuff we'll talk about, but this is the basic idea of the Rush exam. All right, so let's start off with the heart. So you just need 2 views. You could do the entire echo sequence later on, or if the patient starts getting better, you could do it right now. But the point is to do this Rush exam quickly and just get a glimpse of each of the various body areas and not really spend the time you're going to spend for their formal exams, which you're going to do subsequently. So you really only need 2 views for this purpose. So you're going to get a parasternal long view. And I'm not going to see the beauty of not knowing much about ultrasound and having a course like this around me is I'm just going to tell you the general gist of this stuff and let the experts talk about each of these individual exams, because this is really a talk about sequencing and reasons why. So I'm not going to go into how to do the parasternal long axis. You've already had that, but you're going to get that shot. And if you can't, and on a lot of these sick patients you can't, then just get the subxiphoid and it'll do almost as well for you. So either way, you're going to get a reasonable shot of the left ventricle, whether in parasternal long or in the subcostal views. And you're also going to get an idea of whether there's a pericardial effusion. That's what you're going to do in these 2 views. And then you're going to look at the apical 4 chamber, which is a tougher view to get, and oftentimes you have to reposition the patient a little bit, but that's going to give you an idea of the comparison between the size of both sides of the heart. Now, once you've got in those 2 views, I do apologize for the slowness of this computer today. Something very evil is going on. Okay, once you get the 2 views, then you're really going to ask yourself just 3 questions. And the 3 questions are, is there a pericardial effusion? what is my qualitative, not quantitative, my qualitative view of left ventricular function? Just one little look. Is it normal, bad, or overly good? That's it. That's all you need to know for LV function. And then, is the RV dilated? These are the 3 clinical questions you're going to answer with these heart portions of this exam. Just killing the pace of the lecture here. Okay, so basically, you don't need to know the complicated stuff if that's still troublesome for you to figure out. Is this tamponade? Is it not tamponade? What is going on? Basically, if all you knew was that there is fluid surrounding the heart and the patient is crashing, they're hypotensive, they look horrible, that's enough for you to either call in someone to go further or call in someone who could do a better echo exam if you don't feel you're ready yet to make that decision. But that's all you're looking for here is this might be the cause. That's what a lot of this rush exam is. It's just figuring out potential causes, and then we know as ED docs what to do about those potential causes. And for this, if you can't figure out tamponade or not, then you just know you have to call someone in or transfer the patient as you stabilize them to somewhere where they either could do a better echo exam or do the definitive treatment after analyzing this. If you are a little savvy, you could find whether or not there's RV collapse, which is pretty much what I'm looking at. I don't even bother with the RA because our probes are so bad. And I'm sure you've heard the analogy of the man jumping on the trampoline here because that's where I learned it, was from this course. So that's exactly what you're seeing. You're seeing like a little guy just jumping on a trampoline up there on your RV. And if you see that, then great. And if you don't, again, you just have to call someone who could do a better exam. And there's another case, nice little circumferential fluid. Now, I'm sure this has been mentioned, but it bears repeating because this could be really embarrassing. So I think it's worth repeating if you have heard this during the course so far, is you don't want to confuse a pleural effusion with a pericardial effusion. And it's super easy to do. And there's been many a resident in our program who's called up the cardiologist at 2 a.m. and said, you have to come in and do a formal echo on this patient. And they come in and they're friggin' pissed because it's just pleural fluid. And so if you can, in your parasternal long shots, you got to find the aorta, the descending aorta, which is that little black structure right there. And you want to make sure that whatever fluid you're seeing is anterior to that aorta. That's really the key. The pleural fluid will gather in the same place, and if this, this is a simultaneous pleural and pericardial effusion, and if this pericardial effusion wasn't there, then the, bright pericardial structure would be right up against the wall of the heart, and you wouldn't see this for contrast, and all you'd see is a big black, area of fluid surrounding the posterior of the heart, and it's very easy to start convincing yourself that this hypotensive patient has a big pericardial effusion and start a whole bunch of things in motion, like either calling people in or sticking needles into the chest, which doesn't work out so well. So please, make sure, if you can, you either find the aorta and make sure it's anterior, or, if you see it circumferentially around the heart, then that's a pericardial effusion. All right. The thing about pericardial effusions is they could look fine, and then 10 minutes later could be near death. And it's just because the transition point from when the pericardial pressure goes from relatively low to super high is a very steep slope. So a very small additional accumulation of fluid or a very small change in the patient's compensation could really radically change their clinical course, to go from perfect blood pressure, sitting there talking to you, to all of a sudden near dead or coding. So when you find this, you can't blow it off. And I find the junior cardiology fellows who haven't yet had a case of one of these dying in front of them are oftentimes, they'll ask you for the vital signs, and you'll tell them, and they're like, don't worry, we'll come see him tomorrow. You can't let that happen if you really think this is the cause of the patient's problem. Sometimes there'll be an incidental pericardial effusion, like in your renal patients, there's always some fluid there, and they're looking okay, fine. But if your patient looks sick, and they do have any degree of pericardial effusion, you got to be really scared of them, because they might just be compensating right now, and one little further hit, and they're coding. And we've had cases, not at the hospital I'm currently at, because I'm not allowed to talk about cases at the hospital I'm currently at, or I get fired. So we'll just say at another hospital I was at, where patient with an obvious pericardial effusion with ventricular collapse, but perfect vital signs. They let the patient wait until the next day or they hope to wait till the next day and bring them into the cath lab, and patient coded in the middle of the night, and it's never a fun scene to have to do pericardial centesis in the middle of a cardiac arrest. It never plays out as well as you like. Even if you get the stuff, it's not fun. People wind up getting stuck. It's horrible. So don't do that. Don't let these guys go. All right. So that was the first question. Is there or is there not an effusion? The next question, what is the LV function? And you're just getting information here qualitatively. You don't need to actually assess. So you got a normal LV there. You see the mitral valve moving nicely towards the septum, and you're feeling pretty good that the heart at this stage is probably not the reason for the patient's hypotension. I mean, there could be other heart problems going on, but they're probably not the reason for hypotension. As opposed for this patient who's barely moving at all. I mean, this is just horrible. This patient, this might be the problem. I'm not a real savvy on this stuff, but this doesn't seem good to me. And when you see stuff like this, you might not even know the cause now. But the beauty of intensive care is you don't need to be that smart. When you see a heart like this, you just say, bad, and you fix it. And then later on, you figure out all the reasons. And then you just pretend you knew all along what was causing it. But most of the stuff we're doing in intensive care, we're just, oh, that doesn't look good. We better give them something. And this will advance. And then this is a hyperdynamic LV. With the hyperdynamic LV, usually the left ventricular walls will actually be slamming into each other, which seems like a good thing, but it's a sign of actual bad stuff going on. Now, there's two bad things that could be going on to give you an echo like this. Either the heart is underfilled, or their afterload is too low. And now what you'll see very classically in these septic patients, like did you ever learn in medical school that septic patients are supposed to be hyperdynamic and vasodilated? Did they perpetrate that? Yeah, that's a big lie. I mean, it's true when you take them before resuscitation. They'll look like this. They might be hypotensive, their skin's all warm, and they have a slamming ventricle. So this is the hyperdynamic vasodilated state. What you'll find is if you give them a bunch of fluid and you bring their map up and they're no longer have these wide open arteries, all of a sudden their heart goes to crap. And that's pretty classic as well. So seeing this initially in a septic patient should no way reassure you that their heart is doing well. If you take anyone and you give them massive vasodilation, it's lost all the resistance that the LV was pumping against, and it is capable of doing amazing work. As soon as you bring up this patient's map, their heart function will oftentimes go to crap, and I'll show you what that looks like in just a bit. So don't be reassured. These patients need to be re-echoed. When you see an echo like this up front during a rush exam, you have to do subsequent echo exams to see what's going on with their heart. Because this heart looks great right now. It looks like it's a champ doing a lot of work. And it will look really crappy if you come back after you've started your vasopressors. All right, so there you go again, another hypodynamic LV. And I think I got one more hyperdynamic. Let's see. So there you go. Wow, that's super slow-mo. Okay, so that's the second question. We said, is there an effusion? What's our general idea of LV function? And then, is the RV dilated? All right, now why do you care if the RV is dilated? What are you thinking of a hypotensive patient with a dilated RV? PE, right, that's the first thing you think about. Now, it's not necessarily PE. It could be other things. It could be a right ventricular MI. That will actually do this. It could be they just have baseline pulmonary hypertension or high right-sided filling pressure. And as a result, you got to be careful here. Now, if you're really savvy, you can look at the ventricular wall and decide if it's hypertrophied or not, to decide if it's chronic. I can't do that. Again, I just play this the same way I play it in infusion. I just say, okay, this is one more piece of information. If I see a big RV and it's in the right setting, then I'm going to go further and look for other signs that this might be a PE. And if I can't do that, then I might get a subsequent study, like I might rush this patient over to CT scan. Or if they start coding in front of me, big RV, no contraindications, then this might be a patient I'd go down a lysis pathway because now I have this piece of information plus the fact that I haven't figured out anything else and I have a patient coding. So it's just one more piece of information. Here's another one. And essentially, if the RV is the same size as your LV, you're already at the point of dilation. big RV. Really, even less than that. It should be 70%, 60% the size of the LV, but I could pretty easily eyeball, it's at least as big as the LV, and if it starts getting bigger than that, then you got some problems. And you could do magic, like putting some color flow over the tricuspid valve and seeing if there's regurg and stuff, but that's beyond this basic level rush stuff. All right, so if you do see that, it's worth taking the time to add on the supplement of looking at the legs for the DVT. And it doesn't take long to do the DVT. I mean, essentially, you could just do 2 views, one in the groin and one behind the knee to look at the popliteal and get a pretty good piece of information. Though when I have a sick patient and I see that big dilated RV, I like to go further and do a really careful DVT exam because sometimes you'll find stuff lower down in the calf. And if you just find one clot in the setting of a big RV and a crapped out patient, that's a PE. And sure, if you want to confirm with another exam and they're stable enough to do it, great. But if you can't, that might be a patient. You start making the presumptive diagnosis of pulmonary embolism at that point. And I should say, at any point, if you guys have any questions, please stop me, because I left a bunch of time in here for questions. Yes, ma'am?
Just wondering for the heart, because the fourth chamber is always the most difficult to get. Do you ever just maybe do the pericardial short and look at the ventricular size?
Yeah, you can. In fact, for me, if I can't get the 4 chamber, that subcostal also gives me, as long as I'm cutting the angle right, a pretty good idea from a qualitative standpoint what's going on. And you'll see a big RV there. So I don't usually go to the short axis, though you absolutely could. But usually, if I can't get anything, I could at least get a subcostal, and that'll give you most of the information. But essentially, this patient needs all of their views pretty early on if you see any qualitative abnormality. Anyone? Any other questions? All right. So that was the heart. Now we'll move on to the IVC. Now, I'm going to be talking about this in conjunction with Mike Stone a little bit later, so I'm not going to go over this as much as I normally do, because 2 of us are going to debate our relative takes on this in just a bit.
Oh, and they do. Look forward to that in the near future right here on the podcast. For now, though, it's time to digest. This is a lot of info. Make sure you've got it. If not, listen again. And if you want to come hear Weingart in person talk about critical care ultrasound, remember, CastleFest 2014 registration is open. Go to castlefest2014.com and register. We'll have Rush Part 2 for you very soon.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.